Hello and welcome to our cardiovascular imaging conference from the DeBakey Heart and Vascular Center. I'm Dr. William Zoghbi, Chief of Cardiology here at Houston Methodist. It's a pleasure to welcome you here in this conference. Today, I think we will be tackling a topic that is, I think, germane, particularly to adult cardiology, which is prosthetic heart valves. Yes, we would like to repair valves most of the time if that is possible. However, a lot of patients may not be able to be repaired, and you have to use a prosthetic valve in those situations. So today we will start with an overall evaluation on general considerations of prosthetic valves and focus on the aortic valve. With me also will be Dr. Chang, who is the Director of Cardiovascular Imaging at Houston Methodist West, Associate Director of the lab here, and who will be addressing advanced imaging with CT and MRI in the applications of evaluation of prosthetic valves, particularly the aortic valves. And I know we will have a session on mitral valves and other valves later on. So let's get us started. And this depicts, the various prosthetic valves that are used in humans to replace the native valves. And some of them are rather obsolete. Obviously, the ball and cage valve, it is from a historical perspective. However, we deal with mechanical valves still in the younger individual, particularly the bileaflet valves that you see there, in addition to bioprosthetic valves and over the past 10 years or so, nowadays percutaneous valves in the aortic position and other positions. So this is what we're going to try to evaluate today. This is the complexity of these situations, which tells us that as a sonographer or a clinician taking care of these patients, you would really like to identify what type of prosthesis these individuals have, in addition to what the size of the prosthesis is, because it's really very important. Now, there are two recent guidelines, and I was honored to chair both of them. One in 2019, which deals with residual regurgitation in percutaneous valves that put in different positions. And the most recent one, which is the guideline for evaluation of prosthetic valve function from the American Society of Echo, as well as CMR and the Society for Interventional Imaging. So I would like to refer to these two guidelines because they go in depth into the various evaluations and how to, all the technical aspects, and we're gonna try to highlight, the essence of these guidelines today for you. So when we evaluate prosthetic valves, we look at structure in addition to function. Now, structure depends, obviously, if it's a mechanical or a bioprosthetic valve. You look at the mobility of the occluder and mechanical valves, the leaflet motion. Is there a valve thrombus or pannus when you're suspecting stenosis with high velocity and gradients? And is there any infection? Because obviously these valves are prone to endocarditis and associated complications, abscesses or fistulas. From a functional point of view, we look at stenosis or regurgitation. So these are the two areas that we will always look at. Is the velocity and gradient normal for that particular prosthesis? What is the effective orifice area? Yes, you can measure, particularly with CT or TEE, or even MRI, an anatomic valve area in biological valves. And in valve regurgitation, is there any valve regurgitation? Is this built-in regurgitation? Is this more significant, paravalvular, valvular, etc.? So I think these are the important, situations that we will be dealing with. And you will be asked as an imager, what is the function and what is the structure like? This is obtained from the guideline, and I basically divided it into clinical information, the imaging of the valve, in addition to the Doppler echocardiography of the valve. So from a clinical information that we usually should get, and hopefully will be part of your imaging history, is the date of valve replacement, the type and size of the prosthesis, height and weight and body surface area, because there is an entity of prosthesis-patient mismatch, keeping in mind that in the presence of obesity, flow may not necessarily be increased, so just dividing by body surface area may actually be misleading, so you have to be careful about that. Symptoms and related clinical findings and the indications for such an imaging, blood pressure and heart rate certainly very important in valves in the mitral or tricuspid position because it affects gradient significantly with the diastolic filling period. Imaging of the valve, I know we're more limited in transthoracic echocardiography as to the opening and closing of the valve leaflets and mechanical valves and otherwise. Transesophageal certainly much more helpful in those situations. You look at the sewing ring and the position of the sewing ring and any other issues. Remember also that in echocardiography, as opposed to CT and MRI, it really depends on the position of that valve. Is it in the aortic position, mitral, tricuspid, pulmonic? Because it will affect the ability to evaluate this valve fully. Best is in the mitral position, I would say 100%, and it is reduced in particular in pulmonic valve position. In aortic, you're on the side as opposed to en face view, so there may be some dropout. Tricuspid, best in transthoracic because it's closest to it, but also in esophageal, it has its own views because of shadowing of the structures before it, which is the aortic valve and other structures of the heart. Doppler, we will talk about velocity, gradient, Doppler velocity index, and effective orifice area. All these are very important in your overall evaluation of valve function. Echocardiographic images, including 3D, and this is from the guidelines also, for biological valves, including the TAVR valves, different kinds. One thing that's important, irrespective of valve position, is what are the determinants of velocity and gradients. Valve size, I think, is always very important because the smaller the valve, remember all these valves are relatively reduced compared to native valves. The smaller the valve, the higher the velocity and gradient, and that could still be normal for that particular valve. So replacing it is not going to change what the situation is. There is a later push for enlarging, particularly in the aortic position, enlarging the annulus and the aortic root to fit in higher valve sizes so you have less prosthesis mismatch. Valve type is also very important. biological valves versus a mechanical valve, particularly bileaflet valves. Flow rate, I think, is very important because the higher the flow, the higher the velocity, and the higher the gradient. So you have to think, is this a hyperdynamic situation? Is this a very low flow situation? And flow is inherent here. Flow rate is inherent with it, the diastolic filling period for tricuspid and mitral valves. Another thing that's important for you is to think as to what is provided by the size that is published from the industry regarding a particular valve and what is the actual diameter. So you hear about 21 millimeter valve, 23 millimeter, 25, et cetera, et cetera. For St. Jude bileaflet valves, it is an inner to inner diameter that is not measured. So what is reported from industry is actually the sewing ring. You could see that from the outside. So you lose about 2 to 3 and at times 4 millimeters depending. You need to know, at least for a particular St. Jude valve, is particularly in the mitral position, a 31 and 33 millimeter valves are exactly the same, and what the difference is the sewing ring is much larger to be able to sew in to a much larger annulus. So the hemodynamics are the same. You may see rocking of the valve in a 33 because of the largest, sewing ring, and may not necessarily mean that it is a dysfunctional valve. Something I alluded to is there is an acceleration of flow in bileaflet valves, and you can see that. So because there is acceleration of flow between these two leaflets, the velocity is higher in between, so it's not a flat flow profile. And by CW, you will measure the highest velocity, and therefore it is higher than what you see in hemodynamically in the catheterization laboratory or other means, and therefore the gradients are higher and the effective orifice area is lower. And this is early data from Dr. Baumgartner from Europe, showing the overestimation of Doppler versus catheter gradients in bileaflet St. Jude valves, as opposed to a bioprosthetic valve that you could see on the right side, or Med-Hall, Star Edwards. We're not seeing much of those. Importantly, for a St. Jude valve, since we're certainly talking about an aortic position, flow rate and size are determine how much overestimation. There could be about 30% overestimation of that gradient. So if you have a hyperdynamic situation, a 19 or 21 millimeter valve, you will have about 30% overestimation of the gradient. Now, is it bad? We adjust for it by publishing normals for those situations, and effective orifice area also published normals, including this overestimation. So when you have an individual who is their own baseline and following them, this is what you're going to see immediately post-surgery or post-implantation. And so this is corrected for, if you will. And remember that in small valves, the velocity and gradients and the effective orifice area are rather, low or high in those situations. So keep that in mind. And that's why the importance of knowing the size of the prosthesis when you image such a patient. And this is a mechanic valve in the aortic position. Velocity is almost 3. Most of the time, normally is below 3, depending even on high flow situations. So take this publication early from our institution. Dr. Shafizadeh was a medical student at that time. And you have the valve, so you know the valve, you know the size, and look at the heterogeneity of mean gradient. You'll be the same for heterogeneity of velocity or peak gradient. This tells you that one effect is the third one, which is flow rate, right? And here you go, you have a 19 valve, and at times you can have a mean gradient of 25 or even 30, depending on the high flow situation. You go all the way to 31, which is a very large valve in the aortic position. The mean gradients are usually lower, but there is a lot of heterogeneity in this, which brings us to how do you decrease this heterogeneity? How do you incorporate flow, if you will? by measuring an effective orifice area. So the effective orifice area you use the same as you would do for a native aortic stenosis. This is the same population that you just saw, much less heterogeneity, much less spread in these values. One thing also to note that in this bileaflet valve, the average is 1 centimeter squared in a 19 millimeter valve. So knowing also that this valve is rather small, we know also there is an overestimation of the gradient, but this is what's reported normal and can be down as low as 0.85 centimeter squared normally if you have a very small valve. Reason to enlarge, if possible, the aortic root to try to accommodate a larger valve and have less of an issue of these valves. A simplification of the continuity equation is the Doppler velocity index. We proposed this many years ago, actually part of the Chavidezé paper in 1991, and it used to be called the dimensionless index. What it is in the aortic position is basically how much did this velocity accelerate from the LV outflow tract through the valve per se. Ideally, if there is no valve at all, if there is no obstruction, the velocity stays the same or increases a little bit. But obviously you have some obstruction to flow because of either struts or a mechanical prosthesis, so the velocity accelerates. And therefore, this ratio of velocity before to velocity through will be less than 1. It'll always be less than 1. And normally, in this population here, you could see that it's about 0.4, 0.45 for a St. Jude valve. Interestingly enough, because you're taking away the diameter of measurement, which relates to the size of the prosthesis, you could see that there is less variation, still some, but less variation, less relation of this DVI to the size of the prosthesis, which makes it easier in case you don't know what the size of the prosthesis is, that this DVI usually normally is greater than 0.3, usually about 0.4 or so ratio. Now for percutaneous valves in the aortic position compared to surgical valves, percutaneous valve has a better flow profile, less obstruction. So therefore, the normal in the literature, a DVI greater than 0.45 or even greater than 0.5. And we'll talk about that because the positioning of the pulse sample volume will really determine what the Doppler velocity index is, particularly in these valves. So an example of normal versus obstructed valve, you could see that there nicely. What happens is, obviously, with an obstructed valve, velocity increases significantly. Ejection time is longer. Acceleration time, which is the time from onset of flow to maximal flow, increases. And obviously, mean gradient increases. And so a few things regarding TAVR valves compared to the SAVR valves. One is the TAVR valve is in a metallic shell, basically. It's a metallic frame. So there is a narrow portion before you get to the valve per se, which causes some issues regarding how do you determine DVI and effective orifice area. Also, it causes issues for aortic regurgitation, as opposed to where you have just a planar area where you saw the valve, and basically it's a very distinct area, right? So it has better hemodynamics, just like we talked about. So DVI is larger, effective orifice area is larger. The frame extends variably into the LV outflow tract, affecting measurements of diameter in that area and positioning of your sample volume. Challenge to define the site and course of aortic regurgitation because it can be serpiginous in that area and can be difficult, which also tells you for you to assess where the site of regurgitation is, you have to do scanning. You have to do a sweep for you to be able to see where that smallest area, vena contracta, is. This is particular here. The position of the pulse sample is particular to these TAVR valves, right? So what is recommended, and what is recommended in the literature and in these, sites where most of the measurements were done for clinical trials, is that the diameter is measured like in the top portion here, just below the frame, which is larger than inside the frame. And therefore, the pulse sample volume has to be just before the frame itself, okay? And this is the VTI that you're gonna get. If you go inside the frame, and at times you may not have any option to go inside the frame because the frame goes quite deeper into the LV outflow tract. If the diameter is small, much smaller, and therefore pulse sample volume has to be inside. Ideally, either measurement should cause the same stroke volume measurement. A larger diameter, smaller TVI, smaller diameter, larger TVI, right? So ideally, effective orifice area would not be changed. You know that CW jet gradient is not changed because it's irrespective of the position. What will change is the Doppler velocity index, because you're taking away the diameter. Velocity has already accelerated, so what would happen is if you have the pulse sample volume inside the frame, the DVI is much higher. And that's why at times you see in the lab a DVI of 0.8, 0.9. Why? Because it's inside the frame just before the aortic valve. If you tell me the truth, if you tell me what I would have loved in that these banks of normals, is that the pulse sample volume should have been inside the frame, because then you're measuring the functionality of the valve per se. But that's what we're dealing with. So take a look. Before you call a change, take a look where the pulse sample volume was, what the DVI is, because the highest variability in this 4 TAVR valves is where the position of the pulse sample volume for DVI and how did you measure stroke volume for measurements of effective orifice area, okay? So what suggests stenosis, obviously higher numbers of velocity, gradients, a low DVI, et cetera, et cetera. You know, this has not really changed over time from the first prosthetic valve guideline back in 2009. Remember, there is this entity of prosthesis mismatch. It occurs more often in the aortic position, but it can certainly occur in the mitral position if you have a lot of annular calcifications and you have to put a small valve. You know, a 25 millimeter valve in the mitral position will cause prosthesis mismatch. So remember those. And also remember the effect of obesity, a higher body surface area, just a division of area divided by surface area can be misleading. So for BMI greater than 30, the cutoffs of moderate or severe are certainly much less because of that situation, right? And why? Because obesity may not necessarily require a higher output, right? Because we have less blood going to the obese tissue as opposed to somebody who's much more muscular and you have a higher output. You know, ideally, actually, we should index to height, which is less influenced by the total BMI, et cetera. And this is from the guideline, is how do we assess prosthetic valve when the prosthetic valve velocity is high, is more than 3 meters per second. Take a look first at the jet contour. Acceleration time ideally should be less than 80 milliseconds. The ratio of acceleration time over ejection time less than 0.37. So if you have a much rounder contour, this is of concern because of concern of some obstruction. Next, you take a look at the DVI, and normally it should be greater than 0.3, you know, closer to 0.4 or so. Remember of where you're measuring the pulse sample volume. And if it is very low, less than 0.25, obviously very concerning. And if you put that together with the acceleration time and the ratio, you know, usually, I mean, this is what the abnormality is prosthetic valve stenosis. So these are the various issues there for you. Another recommendation for you down below, as you could see, the last gray assessment of mechanical valve motion, fluoroscopy and CT is better than transesophageal echocardiography to assess stenosis or normal function. And the reason for it, as you could see here, is I'm showing you among the better views, is most often you may not see actually well. You may see that it's moving, but you may not be able to calculate, you know, in a mechanical valves, you know, may not be able to calculate, you know, the angle of motion of that valve and whether both of them are really moving very well. So yes, you could use fluoroscopy no dye, obviously, and there's an art to that, to tell you the truth, because I've seen some fluoroscopies that may not be that revealing. And more oftenly nowadays with CTA available is you could use CT without the angiography if you're concerned about motion of the valve only, and you're concerned about somebody with nephrotoxicity, if you will. But CTA will show you both motion in addition to whether there is a pannus or thrombus formation. I know we'll talk about that, but it's not all non-phenomenon. There is mixture of pannus and thrombus, but irrespective, you'll be able to take a look at whether there is really something obstructing the valve. When do we get concerned about changes in function in a TAVI, and this is also in the guidelines? You look at changes in mean gradient, DVI, and effective orifice area. If there is a possible stenosis, when increase in flow and gradients between 10 and 20, a decrease in Doppler velocity index or effective orifice area. Always remember, to compare that to the original study that you had. And nowadays with electronic health records, these are much more available among institutions, so you should be able to tell that. There's an entity that I'm pretty sure Dr. Chang will talk about it, attenuation leaflet thickening, which is HALT. And you could see that very nicely here in this example. And after anticoagulation, the motion of the valve per se got better and the gradient went down. So if there is an important message is each echocardiogram post-surgical, ideally, yes, you do it about 3 months or so, but most often you will do it pre-discharge because of not only looking at the valve per se, but you want to look at the ventricle and see whether you need to change medications, and you take a look at and see if there is any effusion or other things. But this is very important because this is a fingerprint for each particular patient that you will follow down the line. Regurgitation is a little easier, although can be challenging from time to time. As opposed to mitral, aortic regurgitation is not obstructed by shadowing of the prosthesis per se, because either in the parasternal long or short view, you should be able to detect the regurgitation. What is more concerning usually in those is most often is not valvular, it's paravalvular. And whenever you have color Doppler in the paravalvular area, it's an eccentric jet, or there is issues with detection of that in addition to assessment by usual color Doppler criteria. So vena contracta is harder. The jet height to LVOT height certainly does not work as well at all because of impingement of that jet on either the anterior or the posterior structure. So you have to use either flow calculations, pressure half time with its own limitations, reversal in the aorta, so you have to use a multi-parametric kind of situation. So indications of severity, aortic valve, LV enlargement. Remember that some of these patients may have LV enlargement to start with because of their intrinsic disease that required a valve replacement. So you want to take a look at that, and particularly over time. Take a look at the proximal jet width, vena contracta, PISA, beware of eccentric jets, intensity of the jet, pressure half time with its own limitations. If you can calculate regurgitant volume and fraction, I think that's probably the most solid of them all. Diastolic retrograde flow in the aorta is helpful, is specific, but not sensitive. Meaning if I don't see a diastolic flow reversal, it does not mean it is not significant aortic regurgitation. So it's specific, but not sensitive enough in those situations. TEE obviously will define that further, and usually you complement transthoracic with transesophageal, and the reason for it, transthoracic, you will shadow the posterior structure portion of the annulus, and then transesophageal, you will shadow the aortic, the anterior portion of that. So both of these will complement each other to try to understand where the lesion is, where the regurgitation is, the mechanism of regurgitation. And you could see here a paravalvular dehiscence with an early abscess formation that you could see it there in the mitral aortic intervalvular fibrosa. Few things regarding TAVR. as opposed to a surgical dehiscence, where if you have a surgical dehiscence, it occurs mostly in one area, either small or large. To start with, if the apposition is not as good in these sutureless valves, you may have punctate areas in different areas of aortic regurgitation. And at times, they may be on one side or the other, so you have to use tangential views for you to be able to see it. So you need to have a good sweep in short axis, and once you determine something, you may go offline to try to identify where the aortic regurgitation is, and you could see that here in this case. You have to go in the right lower area. You have to go very eccentric. You're not seeing the valve anymore. You're trying to see where the issue is of regurgitation. Now, in the catheterization laboratory, we have several of our colleagues who are interventional echocardiographers. You're limited as to what you could use. Nowadays, we use transthoracic much more often than transesophageal, but besides color and some reversal of flow in the aorta that you've done before and after, use hemodynamics, and not infrequently, if you're concerned, you would use some angiography to try to determine whether you need further expansion or another manipulation. The sweeps are tricky, meaning, take a look at this example. The jet comes from the paravalvular area and may either stay the same or hug or come across the LV outflow tract. So just imagine if you take a measurement just in that eccentric jet, basically you're all over the place. You cannot assess severity. So you have to do a sweep, very slow sweep, till you see in the red arrow the vena contracta area, which is the smallest area where aortic regurgitation occurs. Remember, this is a frame. So you're going to see part of the frame all the way through. So you try to identify exactly where that area is. And this is probably the best measure by color Doppler of severity, the vena contracta area. And you can have one area alone. You can have a small spread area, just like in this example, or you can have a very extensive multiple areas. So therefore, it is up on the sonographer who's ever doing the study to maximize this view. A nice sweep, optimizing color, at times it's difficult, and you could do the same by transesophageal echocardiography, just like you see here. And this is from the guideline of how do you zoom. So this is a modification of native aortic regurgitation. If you could do quantitation, I think that would be helpful for regurgitant volume and flow. Take a look at that red box in the upper area, vena contracta. Vena contracta area is important, particularly in these TAVR valves. And the jet for jet in the LV outflow tract has to be central. So you have to have central regurgitation, otherwise you're not going to be able to really tell what the severity is. And last slide here is just a reference, and I know Dr. Chang probably will talk about it, this is from the guideline. We wanted to give you a relative comparison of each one of these modalities. So you have transthoracic. Transthoracic is phenomenal for hemodynamics and gradients. This is the best compared to any other modality, is the best. Transesophageal, obviously, you're concentrating on structure much more than function, and the function could be regurgitation, site, extent, vena contracta area, but less hemodynamics unless you're dealing with a mitral valve. CT, phenomenal for structure, and irrespective of the position of the valve itself, be it aortic, mitral, etc. CMR, less impressive compared to that, may tell you something regarding regurgitant fraction and regurgitant hemodynamics, but from a visualization of structure, there's a lot of shadowing, a lot of interference, with the pictures. So usually after a transthoracic, you're gonna have to decide, do I do a TEE or do I do a CT? An MRI at times in areas of where regurgitation is. Notice that in this table, we differentiate between positions. If you take a look at valve structure, the second one here, for aortic is not as good. For mitral is superb, is 100%. So you have to think of what valve you're dealing with for you to be able, to decide on what is my next step to image, this particular structure. So in conclusion, clinical evaluation, know the valve type and size. Baseline echodoppler surface is certainly important after surgery as your baseline. It is the first line. In cases of high velocity and gradients, compare with previous studies. X-ray for mechanical AV valve and patient mismatch, be it fluoroscopy or CT, TE for others, CMR in some cases of regurgitation. And I'm going to invite Dr. Sumin Chang to come and share his perspectives on advanced imaging. Thank you very much.
Thank you, Dr. Zoghbi. You did the most difficult part, which is the intellectual portion of assessment. My job's a little bit easier. I'm going to show a lot of pictures. Okay, disclaimer, my talk would be based on CT. I don't think I may do justice to Deepan or Muaz that I talk about CMR or PET, which has its own place in evaluation and assessment. So I apologize if you expect me to talk about CMR or PET. I do show some picture of it. Okay, so most of the valve that we encounter in the lab right now, we see some mechanical valve. We see a lot of tissue valve, and we're seeing a lot more of the percutaneous valve. I would say my slides 2 or 3 years ago had probably 10%, 20% of a TAVI slice. Now I probably have over half. Okay, so when CT can help prosthetic valve assessment, I think when you have elevated gradient, suspected obstruction is very good, especially for the aortic valve position, and I believe tricuspid valve and pulmonary valve as well. And it also can help you determine the etiology of dysfunction, such as pannus, clot, degeneration, or other unexpected finding. For regurgitation, it's not as useful as obstruction, but it's still useful occasionally to differentiate when the color Doppler is equivocal with a very eccentric jet, the patient have transvalvular or paravalvular leak. And also, I think very importantly, CT is often ordered once you already have diagnosis of paravalvular leak to plan for transcatheter closure of the paravalvular leak. That's probably the main reason why we get a CT nowadays for regurgitation lesion. For infection, again, it's very useful. Not so much to see the vegetation because our temporal resolution is bad, and we almost never see small vegetation. I think the sensitivity, we're talking about 30%. But it's critical to see the involvement of the paravalvular tissue to plan for the intervention, either surgery, mostly surgery. Okay. All right. So I'll start with one case. This is Dr. Little's patient. The patient come in with, I think, heart failure symptom, clear obstruction, okay? TE was performed. So the etiology, so we know the patient has obstruction, but the etiology is unknown. So the CT was performed. You can see the 2 areas of hypoattenuation, and one appears to have, lower attenuation of 56. The other one is a little bit higher, in the 80s, and the location is also different. One is above the leaflet in the aortic side, and one kind of underneath in the LVOT side. I don't know if this helped a lot, but you can see clearly the valve is not working well. So heparin was started, didn't change too much, and patient was giving TPA, significant improvement of the gradient from essentially dramatic response. And follow-up CT shows, interestingly, resolution of the supravalvular hypoattenuation area, but persistence of the subvalvular hypoattenuation. So I think this gives us diagnosis of there's both mix, they're both pannus and clot in this patient. Look at, even with one leaflet, kind of stuck in a closed position, the gradient significantly improved. Okay, so how do you differentiate pannus versus clot? So pannus usually is a more long chronic complication, and clot can happen anytime depending on the level of anticoagulation. And usually the location is, it's subvalvular for pannus, supravalvular, or anywhere else for clot. And the Hounslow unit is lower with clot and higher with pannus because it's inflammatory tissue. But I think this is a general assumption, and oftentimes works quite well. Again, Dr. Zoghbi already talked about this. I'm not going to, again, just really emphasize that opening angle and closing angle can be performed with non-contrast gated cardiac CT. Okay, so this is the opening and closing angle. There's two ways of measuring it. So regurgitating lesion, so we talked about the potential role of CT earlier. So case like this, we have a huge gap and huge, jet and CT. So this is not a diagnostic issue. So it's mostly for planning to see the gap is too big to close. So that's for mechanical aortic valve with paravalvular leak. So this is a case I think highlight mostly what we do. So it's not as spectacular as the first case of Dr. Zoghbi. I think this is Dr. Faza's patient. Just happened, I think, 2 weeks ago. So it's a lady who had an ABR done a long time ago somewhere else. We don't know the size. She's been followed a couple of years, and the gradient has been around 25 to 30. I think aortic valve area calculated is about 1.1. And lately, her gradient went up slightly to maybe 3 to 3.5, and the area calculated was 0.9, I believe. I think she's a normal size, 6'5", I believe, 160 pounds. So we can see so TE was performed to determine the cause of the obstruction, and looks like there's some regurgitation as well. So CT was performed. As you can see that she has some area hypoattenuation below the leaflet, and most likely this corresponding to pannus. But other important finding, as Dr. Zoghbi mentioned about St. Jude's bileafleted valve, we can see this is probably a 19 millimeter valve. You can see the internal diameter is 16. And you can see even in the opening position, this leaflet right here appears to be slightly, doesn't open as much as the one next to it. And likely corresponding to this pannus that interfere with a little bit of the opening. Okay. Additional findings include a paravalvular leak. Again, this is very important when you see a defect and contrast CT, you need to find a matching jet, okay? Because you're gonna have a lot of technical issues, and you can cause a lot of paravalvular leak without being there. So you gotta be able to find, so for instance, so this patient has a very good, sorry, let me get back. All right, I can make this play. There was a jet here. This is a gastric view. I'm sorry. So you can see this LV valve coming out here, and this is a jet, and corresponding images in the CT. Remember, CT, you can go back to recreate any image you have in TE. There's no excuse that you cannot find it. You can always find it, okay? And you need to prove the defect that you're seeing is where the jet is going through, okay? again, this is another attempt in a parasternal, in a short axis of aortic valve, and in the, oh, I'm sorry. All right, how do I get back here? Presentation. How do I go back to the presentation mode? Here? Sorry.
Excuse me.
All right. Up to the bioprosthetic valve. So this is a balloon expanded TAVI. See, I don't make too much distinction because the leaflet looks the same, so we're focusing on the leaflet. And then the frame, the metallic frame and the annulus probably get into more into issue of paravalvular leak. So for bioprosthetic valve with elevated gradient, so this is just get you to see what a normal leaflet should look like. Nice and thin, you can barely see it. You really need to adjust the window. So this is a normal valve. Okay, this open time we used to call it normal, but we know this is not that normal. I mean, this, if you look at the previous one, this slide, there's some changes, okay? And this is a self-expanded valve, okay? Complete different mechanism. And by far, the most common cause of elevated gradient in patient referred to us for the workup is degeneration. I mean, and now, I mean, we expect to see a flood of degeneration because a lot of valve was put in lately, and we're gonna see a lot of this. So, but the key here is you can see that calcification, thickening, and sometimes come with a torn leaflet and causing AI. One more word about non-contrast CT is paramount for you to review your non-contrast CT because sometimes the calcification might not be that heavy, and you could have similar console unit as your contrast with the calcium, so you might underestimate amount of degeneration, okay? So this is a case that, I mean, the same patient, you will be able to imagine with the contrast images in the left side and non-contrast imaging in the right side, degree of degeneration, okay? And pannus is always present. I mean, this is a very dramatic case, pannus, documented by histology. And this is a very interesting case. A patient 2 days after the TAVI, the gradient is clearly very high for Evolut 29. And then so some suspicion of endocarditis. So CT was performed, as you can see, was a clear under expansion of the valve. You can see, I mean, and I think the main reason is this patient at bicuspid aortic valve has severe calcification of the leaflet, and that could undermine the degree of expansion. So this is just some unexpected finding of cause of slight elevated gradient. And obviously we talked about halt, and this is just some cases. This is, you know, you don't see this. This is probably, I mean, you can run into this. You probably won't find this. It's, I mean, traumatic response, traumatic amount of halt. And I think we already talked about this. This is the original publication explaining the grade and degree of halt and restricted leaflet motion. But oftentimes, you know, somewhere in between and involvement of different leaflet with different degree of abnormality. Okay, so this is a case of grade 1. You know, 1 may be this one, this may be 2. So, and importantly, you need to understand this could happen almost immediately. I mean, this is a patient who had a TIA 3 days after TAVI just last week. And, you know, there's something there. I mean, it's not completely normal. And important for you to know, this could disappear on its own. And we still try to figure out how to treat it. In any other area, you can also see low attenuation material, like this one here in the sinus, right here. Is it clot? We don't know. What clinical significance it has, we don't know. And then there's another term, less heard, or HAS, hypoattenuation of subvalvular thickening, like right here. Again, the clinical significance, again, the incidence of this finding, it depends how often you scan this patient. One Korean series of 200 patients, they mentioned up to 20 to 30% incidence. And this is another interesting case we just saw recently. Again, this is the second time I see this finding. One was 10 years ago, and this is just recently. You have tremendous thickening, of subvalvular thickening around. You can argue, is this Pannus? Is this Holt? It probably doesn't matter. It's probably all similar, different manifestation of similar phenomena, inflammation, turbulence, and then reaction to the injury. Okay? But the key is, I believe more we image post a TAVR, more we're going to understand. Okay, valvular regurgitation, remember, the same thing with a regular, like any prosthetic valve, it could come from through the, you can come to, this is a prolapse of the leaflet, huge anatomical regurgitating orifice. Okay, I told the fellow never use the word regurgitating orifice because we don't see the regurgitating orifice. You can call it a gap. That's all you can say. Okay, and it can happen obviously with the self-expanded TAVR. This again, Dr. Zoghbi mentioned not only quantification is difficult, localization is very difficult. As you know, it could be just a punctuated area. I mean, my take is, from the experience I have seen is, I mean, always find the calcium. I mean, if you have a calcific deposit in the annulus, likely that's where the leak is going to be. And you can kind of get a sense that, you know, 3D image, quasi 3D images, this part looks like it seals pretty well. You probably have a higher chance of finding the gap in this area. And this is after, you know, quite worked by the right face. And then you need to make sure, again, this that you find match the area that you see the PVL. Okay, let's see. I think it's frozen. There we go. Okay, just. And of course, there are always cases of mixed etiology. Like this case, a patient had, this looks like a very eccentric paravalvular jet by transthoracic. And so again, the importance of matching the same view. And then by close examination of the leaflet, looks like there's a gap. This is a very degenerated valve, so kind of support the etiology also of some transvalvular, and we were able to manage to find a gap. And we went back to look at the TEE right here, and we believe there's also probably a valvular AI is also eccentric. So this is one of those interesting cases. This is some of the complications that could happen with a valve, implant, a BSD. Fortunately, we don't see that almost anymore. And I think next chapter, we're going to be showing more and more is valve in valve. This is a patient who had a surgical valve and had a valve in valve tabby over salvar. So the primary lesion that you can see was flail leaflet and regurgitation. You can see a big gap there. And so second TAVR was put in, so this is his third valve. And 7 months later, come in with severe degeneration. I guess I can only suspect this could be due to unfavorable hemodynamic causing the degeneration. So this is kind of the new frontier. We're going to see more and more in this case. Okay, up to the next, I want to endocarditis. So this is what CT is for. So this is a patient with heart failure, fever, vegetation, and transthoracic. So echo had the diagnosis. There's no question the patient had endocarditis. And I think that kind of a little bit unexpected finding, the patient had complication. That's what we look for in CT. There's a LVOT to RV fistula after the surgery. You can see it's a jet of contrast doing systole and not so much in diastole. I think this is important, and this is another case, a patient with very subtle VSD together with a palpable lead with clinical evidence of endocarditis. Okay, so sometimes this finding could be subtle, so you just really need to look for it. Remember, when you have infection, you can have a lot of associated complication. And again, this is some example of abscess. In this case, was near the left main, original left main. And this one is subvalvular, near the left atrium. And this was done. Patient had suspected endocarditis, so a CT was done a month earlier. And this wasn't seen, but you saw this. Again, this is not normal to have tissue inside the valve. So this probably was phlegmons or whatever, and one month later, patient developed a pseudoaneurysm, and the PET obviously localized exactly where we saw the pseudoaneurysm. Okay, now the mass we see are infectious. I think we have a couple cases, patient with allergy to the alloy used in the TAVI, and I think 1 week, 1 month later, guy show up fever, and to look at endocarditis, but this was not endocarditis. It's purely inflammatory, so it's an allergic reaction. I think it's been reported. Okay, and this is I have to show this case because this is just tell you dramatic case of what CT can see, and in this case, I would say 3D really make a difference. This patient will not come in with prosthetic valve dehiscence, huge paravalvular leak, pseudoaneurysm. They're asking us, if there's any chance to do occlusion. As you can see here, patient had multiple lesions. He had 5 lesions, which are subvalvular, 1 small pseudoaneurysm, 1 huge aneurysm. Pseudoaneurysm has posterior small gap. Okay, I'm sorry, right here. So it has tear, subvalvular, and also, I think this is all connected, also supravalvular gap. Okay, and it was important to show the position of leaflet and systole and diastole, showing that plugging this is not practical because you're going to interfere with the leaflet. So that was very. So this is I think a table from the guideline. I think I confess I didn't read the whole thing. I was mostly focused on the CT portion, and this is one of the algorithm we kind of come up with deepen. If you have a patient with prosthetic valve dysfunction, you get a transthoracic. I think if you have prosthetic aortic valve obstruction, at this stage of age, I mean, our institution might not be unreasonable to go to CT directly. Oftentimes, that's what they do. And if by a prosthetic valve, if you have concern about the quantification degree, CMR is warranted. For regurgitation, 3DT is a king. I mean, there's no question about it. But if you think about percutaneous closure, I mean, you need CT to help you. and we're not even talking about the fusion for procedure guiding. For endocarditis, again, if you suspect complication, CT is a must. Thank you. Any question? Yes, Steve.
All right. Well, first off, Bill and Sumin, thank you very much. This is really outstanding, and it really kind of highlights the value of multimodality imaging. Bill, question for you. I saw on the ASE prosthetic valve guidelines, when you're talking about grading the severity of prosthetic aortic regurgitation, you use kind of the same volume threshold. So 60 cc's would be severe. My question would be, would you modulate that? Let's say, we know for native valves, 60 cc's may be severe AI. Maybe that's debatable even. But what you're dealing with here is probably more of an acute AI, because most of these are aortic stenosis ventricles that all of a sudden develop regurgitation. And it's a ventricle that's very stiff. So in the post-TAVR AS patient, would you modulate how you kind of define severe? Interested in your thoughts.
No data, but I think you have to use your clinical judgment. Acute aortic regurgitation, if the ventricle is not dilated, right, you would rely much more on regurgitant fraction than anything else. I think most people would think if somebody is symptomatic with significant regurgitation, and significant regurgitation in a small ventricle or a depressed ventricle would be anything above a regurgitant volume of 35, a regurgitant fraction above 40%. So, in these valves, obviously patient has been operated on one way, either percutaneously or not. See if you can manage them medically. If you cannot, and what's the underlying etiology of such regurgitation? If you can manage them medically, fine. If not, obviously another intervention is needed. But I agree with you. In the guideline, it's because of lack of data as opposed to anything else. The more you can feed us with data, these guidelines will change. But I think you have to use your clinical judgment. Acute regurgitation, where the ventricle is normal size, or more acute or subacute regurgitation if the ventricle is dilated and depressed. Any of these numbers, for mitral, aortic, anything, numbers have to be modulated to what usually is a moderate severity and above, and regurgitant fraction becomes more important with its own issues. Whenever you deal with small volumes, regurgitant fraction has much higher variability, so more error with regurgitant fraction, although you rely on it. Steve?
So a comment and a question mostly for Sumin. So the comment is you made a very nice and consistent point about gaps on CT and requiring evidence of flow before you really talk about the clinical significance of it. And you and I have exposed many cases, particularly with PVL, where CTs have looked to have a significant gap only to have a very thorough Doppler evaluation with no leak. So I think your approach that mandating flow is critical. And we've had cases where ASDs, native AR, prosthetic valve, paravalvular have been called leaks without evidence of flow. So I think that's a critically important point that you made. The question for you is about pannus. And you showed nicely that pannus on the underside, the pressure and flow side of the aortic valve. On the mitral valve, is it on the pressure side, the LV side, the flow side, the LA side, or how does that work on the mitral side?
I have to be honest. We don't have that many cases that go through our lab for mitral valve. I believe usually what you see is in the LV side. Mm-hmm. Most of the time we see, yes. And the clot mostly in the atrial side.
Because pannus is sort of like inflammation gone crazy.
Correct.
Which in theory, inflammation would be higher on the pressure side. So you'd think the LV side of the mitral and the LV side of the aortic, but Just, okay.
Yeah, I
Curious if
mean,
you'd seen that.
yes, but again, I don't have enough experience to tell you otherwise. But I think Dr. Zoghbi said you probably have both.
From a TE experience, vast majority for mitral is on the atrial side. And actually, how you diagnose thrombosis, actually, we had a case here. How do you diagnose thrombosis is you see something on the leaflet and usually extends somewhere at the annulus or beyond the annulus. It's rare to see it just on the valve itself without some extension. Aortic is harder, because number one, we don't see them as well with transesophageal, so I think the experience from CT is important. I'll share with you a case that in retrospect, we called it correctly, but recent valve surgery, mitral valve mechanical surgery, comes in with atrial fib. And on a transesophageal before cardioversion, there is some obstruction, but there are multiple areas that are dangling from the annulus all the way down to the ventricle. Nothing clean. So I said, well, it's most likely endocarditis. This is not thrombus. Cultures initially were negative. And, better anticoagulation, et cetera. About 2 weeks later, started having fever, cultures were positive, and unfortunately, it had extended significantly. So the characteristics of what you see at times can tell you about diagnosis, although, the cultures may be negative. But in mitral, if it is a thrombus, you're gonna see it somewhere extending on the atrial side. You're rarely gonna see anything on the ventricular side. Other questions?
You guys are too good, so they don't send us enough mitral prosthetic.
I mean, really for mitral, I think the role of TE is superior from any aspect point of view. All right.
Maybe to look at the ventricular side could be a little bit limited.
Yes.
Yeah.
Well, thank you very much for attending. Great to see you.